Okay, so thanks for joining us this evening. My name is Julia Holbrook, and I'm the Executive Director of Karuna Precision Wellness Center. We're a nonprofit located in Indianapolis, Indiana, for cancer patients and survivors, offering integrative therapies like nutrition, exercise, acupuncture, massage, mental health counseling, and cognitive therapy for chemo brain. And our mission is that Karuna Precision Wellness Center leads the way in ensuring every person affected by cancer receives evidence-based, integrative, comprehensive, and personalized care. Our vision: every person affected by cancer has the care and community they need for lifelong wellness. Tonight, we are excited to have Dr. Anthony Magliocco here with us. Dr. Magliocco is a board-certified pathologist and professor of oncology and pathology with over 30 years of experience in tissue pathology, medical research, molecular diagnostics, liquid biopsy, genetics, digital image analysis, and clinical trials. He has founded and led multiple clinical laboratories and has overseen the deployment of numerous new laboratory tests in his career in both Canada and the USA. He has published over 200 research articles, has numerous patents issued and applied, and is a frequent invited speaker to international diagnostic technology meetings. He was chair of pathology at the Moffitt Cancer Center, scientific director of the Tissue Core at Moffitt, and chair of pathology in the National Cooperative Groups RTOG and NRG Oncology. In his extensive peer-reviewed research, he has developed new digital image analysis methods and has created numerous new diagnostic tests used to aid selection of treatment plans for patients with breast, ovary, lung, bladder, and many other cancers. He founded fellowship programs in digital imaging and molecular diagnostics at the Moffitt Cancer Center. He founded the Hereditary Cancer Program in Saskatchewan and was the pathology leader of numerous tumor groups at the Tom Baker Cancer Center in Canada. He also served as medical and scientific director of multiple regional and national tumor banks. His deep knowledge of molecular biology and medicine enable him to identify tests and tools that are unique in their ability to contribute to the future of medical diagnostics. His interest and aptitude for business enables him to create a viable pathway for implementation of these tests and tools. His vision is to move medical diagnostics forward to keep pace with scientific discoveries. Most recently, he founded Protean BioDiagnostics and raised multiple rounds of funding. He has developed the unique oncology MAPS system, currently the only comprehensive precision medicine system aimed at supporting community-based cancer patients and their doctors. He is the principal investigator of multiple ongoing biomarker-based clinical trials. Welcome, Dr. Anthony Magliocco.
Well, thank you, Julia, for that introduction. It's absolute pleasure to be here with you and your group, and really love what you're doing, taking an integrated approach to cancer care and to really supporting people living with cancer. That we know cancer is a terrible disease, troubling disease, and really one that really trying to do our best to combat and reduce the suffering from that. As mentioned, I'm running a company called Protean BioDiagnostics that's really focused on helping patients achieve opportunities for access to high quality diagnostics, linking them to cancer therapies and outcome. We went over my background, but working as a physician, I've had the privilege to work over 30 years and gain insights into the challenges that are facing patients with cancer, and to really live and work through an extraordinary time in scientific diagnostics where we've seen absolute revolution in our ability to understand how to analyze cancer and how to treat cancer. So these are very, very extraordinary times that we're living through. It was estimated that human knowledge used to double every few hundred years and then every couple of decades, but right now it's on the order of every few weeks, the amount of human knowledge is actually doubling, and that we're learning more and more about how cells work, how cancer cells work, genetics, viruses, and so on. So we're moving towards, in medicine, what we call precision medicine. And in the old days of medicine, it was really one size fits all, that we would really, choices for treatment were limited. We didn't really have advanced tools for diagnostics, and we were really using things like chemotherapy and surgery and radiation, really trying to treat all patients with those in a one-size-fits-all solution. Now, thankfully, over the last 15 years, we're moving more towards what we call precision medicine. And precision medicine is where we really, first of all, have to have the correct diagnosis, and then we select the correct treatment for a patient, one that will work for them with limited toxicity, adjust it as needed, and then time it correctly so that it's optimal in its outcome. And if we consider patients with cancer, that basically cancer is a heterogeneous disease, that cancers are different. Different people have different makeups, their genetics are different, they have different exposures. If we were to treat them all the same, there'd actually be quite different outcomes. And as we select a therapy, so for example, if we looked at what we call treatment A, and if it only affected the people who are blue here, if we were to treat the whole population with treatment A, we'd only get we'd only get a few people responding. Whereas if we were able to isolate the blue people first and really assign them to treatment A, the group within the blue group, we would expect to do extremely well. So picking the patients and matching them to the correct treatment is really one of the fundamental goals of precision oncology. Now, in precision oncology, one of the other things is that we want to have more targeted treatments that are really aimed at the cancer, that have less toxicity. So we want it to be focused on the cancer. It doesn't make a lot of good if you kill the cancer and you also kill all of the normal tissue. And this is often the problem with chemotherapy, that you treat a patient with a chemotherapy and they have terrible side effects. They may have diarrhea, they lose their hair, they may get cardiac toxicity, and they may even die as a consequence of the toxicity of the agent. So finding therapies that are effective with less toxicity is really key. And that's what targeted therapies are. Immune therapy is a very interesting new category of therapy where basically cancers or the immune system, we believe that some cancers, or that cancers are arising all the time in a patient, and that an immune system keeps them at bay, and something goes wrong with the immune system and the cancer evades it and then spreads and basically progresses in a patient. If we could restore the immune function, then maybe we could get the immune system to actually eradicate the cancer. We're making extensive progress in this area with immune therapy. So very, very, very exciting times with immune therapy in terms of many different methods for immune therapy and activating the immune system. Radiation is also a very interesting treatment. That radiation is sort of like surgery without having to cut open the patient. So we can deliver energy in a very targeted way so that we can isolate cancers and deliver high energy to the cancer and basically kill the cancer with radiation. One of the interesting side effects of radiation is that radiation might actually enhance immunotherapy. So there may be some sort of interaction in that if we irradiate a cancer, it may actually cause it to break down and release antigens, which can absolutely trigger the immune system. So a lot of things are happening in the area of diagnostics, and what the result is that there's a need for diagnostics. We really need to understand which patient should get the treatment, which patient might be toxic to a treatment, and really move this forward so that we can apply treatments with great accuracy. So the process of really sorting a patient out is really pivots on the availability of biomarker testing and performing it well. Now that's one of the challenges, because if we look at how big a problem this is, that the chart on the left shows the number of drugs that have been approved by the FDA for cancer over the years, going back to 1950. And if we look, there's maybe 1 or 2 drugs a year that would have been approved. So there weren't really that many therapies available. And there was a long time, there's actually years before another therapy would come along, Whereas now, in the past year, there was over 56 new therapies approved for cancer, and almost all of them are linked to having a diagnostic tool that you can't give that therapy without actually the patient having a test, and the test having been approved by the FDA and properly put into a lab. So this is creating a massive challenge in that there are now basically hundreds of different things that need to be tested for to be able to appropriately match a patient to a new therapy. And this is becoming quickly an unmanageable problem in that the pace of discovery is going so fast and the need for new biomarkers is exploding. And if we look at this diagram here, what I'm showing here is these red dots are different kinds of cancer. One of them might be a breast cancer, one's a lymphoma, one's a lung cancer. The green dots are different therapies. So a single cancer may have 20 different therapies or more, and some therapies may be used on multiple cancers. So a physician has a big challenge when they have someone with cancer. It's, what therapy do I use, and how do I pick the right therapy, and is there a risk from this therapy? And this level of complexity is really causing great confusion and challenge. Now, the great cancer centers, one of the networks that is really a leading edge network is the NCCN, or the National Comprehensive Cancer Network, and there are actually only about 25 of these sites around the country, and these are the leading academic centers that are really discovering new therapies, running clinical trials, opening studies, and really doing the very, very cutting edge studies. And if you happen to go to one of these centers, you're going to have access to the latest diagnostics, the latest studies, and so on. But one of the problems is that only about 5% of Americans have access to these cancer centers. And this leaves a gap in that the vast majority of Americans are treated in community cancer practice. And not that that's a bad thing, that the care is good there, but the fact is that if you look at the current community oncology practice, that most of the physicians there have been educated 10, 20, 30, 40 years ago, and that the pace of discovery is huge, so that there's a growing crack that patients can fall into in terms of, are they getting access to the latest effective therapies and treatments that can really dramatically improve their outcome? And unfortunately, a lot aren't. And that's because of these barriers of problems with the community accessing tests, the problems with generalist oncologists understanding what the results mean, and actually the data even getting lost. So even if they do a test, the data might get lost and not into the medical record. So there's a huge number of barriers that really affect the ability of cancer patients to get access to treatment. And this barrier, unfortunately, is growing. And it's one that I have a lot of concern about, and it's one that I've been really focusing my career on recently, on trying to close this barrier and really come up with ways. How do we really connect with patients in the community? How can we help them and their doctors really move forward with access to current treatments and diagnostics? Now, let's talk about the journey of the tissue. So basically, when you have a lump or a bump diagnosed with radiology, often for a diagnosis, a surgeon will excise that piece of tissue. Now, the surgeon and their team do not necessarily know what is this tissue that they're excising. They actually have to send it to pathology. So they may send it to pathology. Here it is. It's been transported in liquid. This is formalin. Formalin's a chemical that actually preserves the tissue. So it's a chemical reaction that kills bacteria and it stops decomposition. So when the tissue is placed into there, it's stabilized and it can stay in formalin for several days and be shipped to a lab. It might be better to analyze the tissue fresh, but this is the way that it was done over the years, that it would be fixed in formalin. And then here a pathologist is taking the tissue out and they're examining it. They're cutting it into tiny slices, and then they're going to put it into these plastic, they're called boats or cassettes. And within these boats, they go into this and then they're processed further. And what the processing involves is putting it through different types of alcohol to remove all of the water. So living tissue is in aqueous solution or in water. Formalin is aqueous, so this tissue is still full of water. And then the next step that has to happen is it get processed to remove the water. So it goes through a processor, and then the next morning, this is a processed specimen, meaning that the water has been removed, so there's no water left in it. And it's in a device here that puts wax on it. So wax is put onto the tissue, and then it's placed into this, and this is just paraffin wax like you have in a candle. And this is a piece of tissue, in this case, a piece of cancer tissue, that has been mounted into this piece of wax. And this is a paraffin embedded piece of tissue. And if you've had a cancer, chances are that one or more of these paraffin blocks are in existence. Labs have to keep them for at least 10 years. In fact, most labs never throw them out. So there are paraffin blocks that are actually hundreds of years old in some of the old labs and hospitals around the world. And amazingly, this paraffin block keeps the tissue stable for almost forever at room temperature. So this can be stored in a cellar or on a shelf. It doesn't have to be frozen, and it's stable in this paraffin wax, basically embedded in paraffin wax. So what happens the next day, so it is stable there, but after this block is made, it's sliced. So here's a microtome and a thin razor, and this is a ribbon. So we're taking very, very thin slices, actually thinner than a human hair. So these are multiple slices through this block, and it comes off as a ribbon. This ribbon is floating in a water bath here, and we can see that there's pieces of very, very thin pieces of cancer floating in that ribbon on the water bath. Now, one of the problems is that if you have a hospital that doesn't keep this water bath clean, there can be little fragments of other people's cancer floating around in here, and that can be a real problem, and that's called a floater. And when you lift up those little ribbons and put them on a glass slide, you might get a piece of another piece of tissue on there, which can be a problem. So having a very good lab that keeps this clean and ways to clean the water and everything between slicing is really important for the quality of pathology. And I point this out that you don't really, sometimes you get to choose your surgeon, but you don't necessarily get to choose your pathology lab or your pathologist, at least for the initial diagnosis. So here is the thin piece of wax with the cancer in it on a glass slide, and then it gets stained. So it goes through different sorts of stains. So in this case, there's an eosin, there's a blue stain. And these stains were invented in China to stain silk hundreds of years ago. And if you were to look at this slide without a stain, you wouldn't see anything because the tissue is clear. So when you stain it, it now gives it this pink and blue color that you can actually visualize down the microscope. So what happens then is that the slides are then brought to a pathologist, and here's your friendly neighborhood pathologist. This is Dr. Musa Khalil, and this is what a pathologist's office looks like, that they have a bunch of cases. So these cases come in every day from the lab. The pathologist looks through the cases down the microscope. This is a two-headed microscope so that they can teach a resident or fellow or actually discuss a case with a pathologist. This is old school, but most hospitals still look like this. So this is the way pathology has been done for about 50 to 100 years. Surgical pathology is done like this. There's a computer in the background. This photo was taken in the early 90s, but you'd have a flat screen monitor now, and actually a lot would not have changed from that period of time. And the pathologist looks down the microscope, determines if there's cancer or not, grades the cancer. So in this case, there's a breast cancer. They decide, is this forming tubules? Is the nuclei irregular? Are there mitotic figures? And they come up with a grade. And this is really important because the grade will actually define the treatment you get. And like I said, you don't always know if your pathologist here is an expert like Dr. Khalil, or if it's someone who has less expertise and may make an error in your diagnosis or miss something. The next thing is that we examine the tissue to determine what is the prognosis for a patient. So This means in many cases of cancer, the patient is actually cured by the initial surgery. So if the tumor is localized, you can cut it out and you're cured. But if the tumor is spread, if it's involving the margins or gone to the lymph nodes, then that tumor is has become systemic. We used to think that tumors that were systemic were incurable, that it was too late. But now we know we can actually have treatments that have very strong effects on tumors that have spread and, in fact, potentially cure them. Treatments like targeted therapies and immune therapies are showing effects of curative effect on patients who have had metastatic disease. And we see, for example, if you know Jimmy Carter, the president, he was on a trial. He had metastatic melanoma to the brain. And back when I was a resident, he would have only lived a month. But he was on one of the first immunotherapy trials, and it actually cured him. And now I think it's something like 15 years later, he's doing extremely well. So these advances are real, and they're making a real difference. We also use markers to figure out what treatment should a patient use. So one, should they get treatment? And then if they are getting treatment, what is the right treatment for them? I'll focus on breast for the point of discussion, and then avoiding treatments that might be toxic are also important. So one of the key markers that every breast cancer has evaluated is estrogen receptor. And the majority of breast cancers are estrogen receptor positive. And we stain the tissue with an antibody that's labeled with a dye so that we can see whether the cancer cells are expressing estrogen receptor. So in this case, we can see the normal duct is here and there's some estrogen receptor expression. This is a normal duct. And here we see cancer invading around the duct, and it's very strong expression for estrogen receptor. The pathologist will count this. They'll determine what percentage of cells are positive, what's the intensity, and then give a score and say this is a estrogen receptor positive cancer. That information will go back to the oncologist. The oncologist will say, oh, I can treat this cancer now with anti-estrogen. This patient should respond to that. So very important step. If a pathologist gets this wrong, again, the oncologist will have the wrong information and then won't be able to treat a patient accurately. Now, if we look at another marker, HER2 has been a marker that's been around for 25 years, and we stain the tissue with an antibody against HER2. And there was a drug, trastuzumab, that came out, that was available in early 2000s. Dramatically, women who had high HER2 expressing cancers did terrible. They advanced and died extremely quickly. With the new treatments of anti-HER2 treatment, they're actually doing equivalent or even better. So the therapy is making a huge effect. But initially, the trastuzumab would only work in women with 3+ tumors with very high expression or with intermediate expression and amplification. I'm going to tell you later in the talk that the tumors that have low and 1+ expression have now, there's a new therapy where the trastuzumab has been revved up with a targeted agent, or by combining it with another drug, and that now we are seeing that tumors that have even low expression might be targetable with this new type of drug, and it's very exciting. I'll talk about that later, about some advances in the HER2 area. Now, one of the problems, I talked to you about how important testing is, and if testing goes off the rails, that there's actually a problem in Canada back in the 2000s where it was discovered that in one of the Canadian provinces in Newfoundland, that estrogen receptor testing was done incorrectly for over 10 years, that they didn't calibrate the assay correctly, and they were calling women estrogen receptor negative when they weren't. And hundreds of women were affected, and they didn't determine the error until 10 years later. And it really, was a terrible discovery that a lot of work had to be done to try to fix the system and try to understand why something like that would have happened. And it was because there was a lack of control in the labs to really ensure that the testing was being done to a high standard and with proper positive and negative controls. So we've learned more about that, and hopefully we've overcome that this won't be a problem in the future. So in Canada, they started doing a proficiency testing. So what they did is they sent estrogen receptor stains around the country. So on the left is estrogen receptor, progesterone receptor. And basically, they sent the same case to all of these different labs. So there's about 30 labs here. And if this is case one and it went to 30 labs and they all thought it was positive, red means positive. In this case here, it went to the labs, and if it was white, it was negative. If it was yellow, it meant that they couldn't evaluate it. And what you see is that there's about 85% concordance, which is, pretty good. But you have to realize that if you're this particular patient here, if you're this woman and you go to lab 1 and they tested your tumor, they would have said, "Oh, it's negative. You don't need endocrine therapy." If you went to lab 2, they said, "Oh, if you're positive, you're going to get 5 to 10 years of therapy." So that's pretty crazy, right? That a test like this can drive 10 years of treatment, and that there's a 10% chance that it's wrong. So that's I think that's not good enough, and that's a real challenge. Then when we look at the other stain, progesterone receptor, here we can see that certain labs, they don't even have to do the test. Every test is positive. So we have to say, wow, there's something wrong with that lab, that they got way too many positives. And then over this lab here, they're all negative. Say, wow, that lab is out of kilter. They're really not performing the test properly. So by doing the interlab comparison, at least we can find labs that are falling off and try to figure out what the problem is and try to standardize testing. But there is this degree of problem in cancer testing, and I want patients to be aware of that. And that's sort of why you need to consider, is your test accurate? Should you consider additional testing to ensure the diagnosis is correct, and so on. And I certainly encourage second opinions and possibly repeated testing before you embark on really, therapy that could last 10 years, therapy that's toxic, therapy that's financially toxic because it's so expensive, and so on. So this is one of the fundamental problems in the lab industry today, is sort of the variation in lab testing from lab to lab, and that's something we really need to address. The other thing is that pathology reports may contain errors as much as 44% of the time. And this is pretty scary. And in fact, when I worked at places like Moffitt Cancer Center, that when a patient came in to be treated at Moffitt, they wouldn't even have the first visit until pathology reviewed all of the outside pathology to confirm, one, do they have cancer? Is it the kind of cancer we think they have? Is the stage correct? Is the grade correct? Is the markers done correctly? If that's all correct, then they can come in for the visit. Otherwise, they'd have to say, well, we have to do the path and make sure everything is accurate, because we can't properly treat your cancer unless we know exactly what it is. So having this second opinion is very important. So a second opinion from an expert can really help you have confidence that your cancer is correct. And I've seen lots of cases, recently I've seen cases that have been called lymphoma, and they're not lymphoma, they're actually lupus. They've been called liver cancer, and they're not liver cancer, they're benign nodules, and so on. So there is a certain value to having that second opinion to make sure that the diagnosis is correct. Another thing that's really transforming pathology is the arrival of digital path. And in digital path, what happens is, instead of the microscope, we actually get a scanner, and a scanner is like a high-powered scanner. It's really just a camera. So the glass slides go into it, and then they're basically scanned by the microscope inside of this machine, and optical image is captured and then stored. Now, the value of having that digital image means that it's now available to share with other pathologists. So you can send it to experts around the country and say, oh, can I get 2 or 3 opinions on this? Can we get an expert that understands this, and so on. So the digital pathology is something that can really transform and improve outcome by, one, just documenting the image, storing it, making it available to others. Because in the old days, when we just had glass slides, a patient would have to take their glass slides around the country and have the other pathologists look at them, whereas now, if they have their pathology scanned, you can send it around to 20 centers immediately, and experts can have a quick look at it right away and make decisions about it. We can also now go beyond humans in that expert systems, artificial intelligence, can now start looking at these images and can help pathologists. So there's software now that can look at a thing like a prostate core. It can automatically scan it and actually identify areas of cancer and score it. This can really help a pathologist because a pathologist might be dozing off when they're looking at the prostate and miss an area of cancer. But if a machine is looking at it at the same time, they can flag it and say, wow, did you see this? Is this the right grade? And it's a very powerful tool to improve quality and make sure the pathologist is not missing anything and help them standardize their scoring. We can also move beyond this and actually start teaching artificial intelligence to see things that humans can't. So in my company, we've been teaching the computer, can you see mutations in the DNA, that this particular lung cancer has EGFR mutations? We sequenced it. We were actually able to teach the software that it could tell whether a tumor had mutations just by looking at the regular slide image without having to sequence it. So this could dramatically speed up the ability to make a diagnosis of cancer and also divide it into what kind of cancer it is, that this is an EGFR positive cancer. This image just shows us where the computer thinks the features are that drive that cancer. A human can't really figure out why the computer thinks that's important, but the computer is calculating things about this, and presumably these have something to do with the presence of EGFR mutation. We've also taught the computer how to predict if a benign lesion is going to turn into a malignant lesion. So we've taught it to predict if Barrett's esophagus is going to progress to cancer with accuracy. So a human can't do this, but now the computer can. So we can take a biopsy, show it to the computer. The computer can tell us, I think this patient needs more intensive screening because they can this tumors or this lesion isn't really benign, it's going to progress. So artificial intelligence is something that's really coming to the path labs. It's really going to change the way we change our diagnosis in the future. The other thing is that we can start visualizing components in the tissue. So here's an example of a piece of cancer where we can now stain it with multiple markers, and we can look at all of the different immune cells. A human can't really count this very well. It can say, wow, this is a really pretty image, and there's lots of different cells here. But a computer can isolate these, count exactly how many CD8 cells are, count the FOXP3, the PD-L1, the PD-1, the CD3. It can do this in a minute. It can count, there's 55,000 CD8 cells. It can determine this tumor will respond to immunotherapy or not, whereas a human would be lost. So a computer can now quantify all of the things that are happening in a tissue. So here we can see it can count all of the different kinds of tumor cells, the T cells, etc. And we can now turn pathology from a subjective person looking down the microscope to a computer that helps that pathologist really count everything and help us classify with great accuracy what sort of cancer is there and how it might behave. Now, one of the other big advances in human knowledge is the human genome, and billions of dollars were spent back in the late 90s and early 2000s to sequence the human genome, and it took like 10 years to do it, and I think $200 billion. It was a massive, massive effort involving dozens of countries and genome centers, and finally we got the human genome sequence in about 2001, the outline of it. And why is it important? Because now we know the library of the DNA. There's about 22,000 genes make up a human. It's kind of interesting. Certain trees have hundreds, 300,000 genes. So humans have a relatively low number of genes. The genes are turned into RNA. So the difference between a brain cell and a liver cell is they all have the same DNA, but they turn on different RNA, and then the RNA is turned into protein. So a pathologist can look at any one of these things. They can look at the DNA, can look at the RNA, and they can look at the protein. So the ability to evaluate DNA is extremely important, and this shows the decrease in cost. So in 2001, if you wanted to have your genome sequenced, will cost about $100 million. But the cost has decreased dramatically, and now we can sequence the genome for probably $400, less than $1,000, and it's going down. This is Moore's law of semiconductors, where the number of silicon diodes doubled every 6 months or something. But the pace of human genetics research has far outpaced that. Dramatic. This is a log scale. This isn't a linear scale. This is 10 times, 10 times, 10 times. So we've actually got a million-fold improvement in our ability to sequence DNA over the last 10 years. 20 years ago, if you went to a genome center, it looked like this. There'd be a building that floors were filled with these sequencers. These are Sanger sequencers. And now we have a little device that sits like this. It looks like a printer, like a printer scanner. It sits on your desktop, and it can do the work of the whole building. And it can run a genome in an afternoon. So this is the technology that now sits in the hospital, can do it ultra quick. Of course, this is a little bit more expensive than a printer. These cost about $80,000 to $500,000, but it's a far cry from a building full of sequencers costing hundreds of millions of dollars. Now, this has transformed diagnostics and care. If we look at lung cancer, that in the old days, we just cared if a lung cancer was small cell or not small cell, or adenocarcinoma. But over the last 15, 20 years, we now know there are many different drivers in lung cancer. There's ALK, HER2, RET, ROS, and now a lung cancer needs to be evaluated for all of these because there's different therapy depending what kind of lung cancer you have. And if you give the wrong therapy to a patient, they'll actually do worse. So it's critical that you do this measurement very accurately. And so if you take a lung biopsy, if we were to measure each one of these genes separately, you'd have to do 12 different tests. We'd have to divide it up. Lung biopsies are very small, and it's very ineffective to be able to do this. So by doing a composite analysis or a rapid analysis, we can actually analyze all of these genes in one go. And so this is a comprehensive genomic panel that's now available for cancer. So over 500 genes, DNA and RNA, fusions, copy number, mutational burden, all in one test. Test all of these in a tiny piece of tissue. This information is phenomenal, really allows an oncologist to determine how to select the right treatments like I showed you before. Now, the other thing that's becoming important is hereditary genes, that we know that many cancers are driven by inheriting a gene, BRCA1, BRCA2, other genes. And it's really important to know whether you have one of these inherited genes because it can tell you, one, are you going to get another cancer? So you might consider a different kind of surgery. Maybe you should have bilateral mastectomies if you're at high risk. Maybe you're also going to be risk at colon cancer or ovarian cancer. You need to measure that. Also, are you passing that gene on to your children, or do your siblings have it? That's important for them to determine what sorts of screening they have. And now it also defines what kind of treatment you should have. So certain tumors, if you do have a BRCA mutation, they should be treated with PARP inhibitors or with immune therapy, etc. So having a hereditary cancer analysis is very important in terms of selecting therapy. So one should always consider that. Now, looking at liquid biopsy, you might have heard a lot about liquid biopsy, and it's a very exciting area, or a different kind of test. And what is a liquid biopsy? So if a patient is unfortunate enough to have metastasis through their body, we can't really biopsy all these metastases to know what's going on. We know that these metastases will be leaking tissue into the blood. And so there'll be cells will be floating around, DNA will be floating around, exosomes will be floating around. So in a blood tube, we can actually measure what's going on in the rest of the body here. What's going on with these cancers? Are they changing? What kind of mutation do they have? Are they responding to therapy and so on? So by taking a blood test, we have a very powerful way to monitor, does a patient have cancer? Is the cancer progressing? Is it changing? And so the role of blood tests, we can use it to diagnose cancer. So there's tests that are coming out that are screening tests. You might have heard of GRAIL, other types of technology. So that's pretty exciting in terms of that. If you don't have the tissue, you may be, wow, I had a biopsy done and there's no tissue left. What am I going to do? Well, you might be able to do a blood test, and we can actually measure if there's still residual cancer in you, what sort of mutations are present. and we don't need a biopsy. We can replace a biopsy with that blood test. Also, following your surgery, you might want to know, did the surgery remove all of the cancer? Am I free of cancer? So following surgery, you might say, wow, you're free of cancer. There's no cancer left. Or there might be residual cancer. Say, oh, you've got some residual cancer. You might need further surgery, or you might need to go on to a targeted or systemic agent. We can also monitor then, is the cancer responding to treatment? So what's going up? We can give a treatment, now it's going down. The cancer's changing, it's got a new mutation. We can change the treatment and continually monitor the patient. So I think in the future, we're going to see more and more use of liquid biopsies. We also may be able to do liquid biopsy using urine so that we can track what's going on with the cancer over time in urine and in blood. So liquid biopsies are definitely going to become more used and really allows us to tailor therapy for a patient where we can understand if they're responding to the therapy in real time. So very, very exciting. So with precision medicine is now a reality, so that really every patient, we really want to treat them as a unique individual. We want to measure their cancer. We want to understand what's going on with their cancer. Now, a lot of updates are happening. Just came back from ASCO, where the world's largest cancer meeting happened. And at ASCO, there's something like 60,000 oncologists and people go to this meeting, and they present some of the pivotal work. And one of the most exciting studies that was presented was something called Destiny Breast 4. And this study, when it was presented, actually, the room was packed. There was at least 3,000 people in the room, and the presenter received a standing ovation. That never happens at a scientific meeting. So the last time there was a standing ovation at ASCO was 15 years ago with the HERA study, so that people were so excited by this study, the Destiny 4 study, saying, wow, this is really meaningful. And what was the Destiny 4 study? So the Destiny 4 is for women with metastatic breast cancer, and that they're using this new agent called T-DXT. And what it is, it's trastuzumab that is also loaded with another drug called DXT or dextrorituxan. And this particular drug is a TOP2 inhibitor. So what happens is that the antibody sticks onto cells and then releases the drug into the cells. And then this chemotherapeutic drug kills the cell. And actually, after the cell dies, it releases it and it kills other cells. So there's a bystander effect, and you get this very, very effective cell killing. So you get targeting with the trastuzumab, you get extremely effective cell killing. And it showed doubling of time to progression in women with metastatic cancer. And it also showed effect in low HER2. So we only know about 15% of women have HER2 positive, and that they're either 3+ or 2++ amplified. But in this study, they also opened it up to women who were 1+ or 2+ non-amplified, and this actually is 50% of women. So this study opens up this new therapy to 50% more women with metastatic breast cancer, and it's showing extremely good promise in terms of efficacy. So that was some very exciting news from ASCO. Now, moving on to how can we help the community practice. So at Protean, we think that being able to provide a complete solution for community oncologists is the way to go, that we can make it easy. Why aren't they using these advanced tests? It needs to be easy. All of these tests are available in one stop. Pathology review, expert pathology, molecular analysis of the tumor, liquid biopsies, hereditary. We want to make everything very, very easy. Using this system, we also think we can speed things up. Currently, it might surprise you to know that if you go to a community oncologist and they decide to order a test like Foundation Medicine, it might take 6 weeks to get a result. So you're kind of stuck in limbo, wondering, are you going to qualify for a trial or not? Whereas we think this needs to be expedited, that some of the markers are available within 24 hours. We really speed this up so that one can get patients onto treatment extremely quickly. So we think for proper care, you need rapid diagnosis, selection of a proper test so that the patients can be properly mapped. It's changing quite quickly in breast cancer as well, because back in the old days, and by the old days, I mean last year, that for breast cancer, we really only did estrogen receptor, progesterone receptor, HER2, and that was about it. But in the last 2 years, there's been approvals of new targeted therapies. For example, cyclin CDK4 and 6 inhibitors. You need to have Ki67 for that. There's PIK3CA inhibitors. You now need to know the mutational status of PIK3CA. There's immune therapy. You need to know, does the cancer have immune therapy? There's a targeted agents against TROP2 and triple negative. You need to know that. You need to know whether the cancer has a BRCA1 mutation or hereditary mutations for use of PARP inhibitors. So the diagnostic field for breast has exploded in the last 18 months. And what this means is that a lot of women with breast cancer are not getting the tests that they need because their doctor doesn't know they should be doing them, or they don't know how to get them. So that's one of the problems. The other thing is that with the advances in liquid biopsy, we can now actually help women determine, is their cancer changing? Because you may find women that were HER2 negative cancers have now turned to HER2 positive. You may find the cancers are becoming resistant to endocrine therapy and that they need to switch their anti-ER, or other things may have to happen. So creating a system that we can really manage breast cancer women in one place is one of our goals. And I think this is the future of really precision medicine, because it has to be up to date. The cancers are smart, they change, you need to be able to monitor them. There's new tests that come, you need to be able to manage the tissue so that there's proper custodianship of the tissue, so that the tissue is available for future studies for the patient, so that additional testing can be done. And I told you the paraffin blocks are available there, that if you had your cancer diagnosed 5-10 years ago, you might still be able to have tests done on it. If you happen to have a recurrence, we can go back to those old tissue and see what was going on with that cancer originally. As it changed, we can do liquid biopsy and monitor it that way as well. So in summary, cancer diagnostics are really becoming more complicated and very, very challenging. Diagnostics are key for each patient. So it's not good enough just to know that you have cancer. You need to know what stage is it. You need to know what subtype it is. You need to know what is it going to respond to. Pathology review is essential. Like I say, you generally don't get to choose your pathologist. And I'll say, what are 3 things a patient can do to improve their outcome? 1 is get a second opinion in a path review. 2 is get a second opinion in a path review. And 3 is get a second opinion in a path review. So getting those done is really, really important, because you want to make sure that you know what is the correct diagnosis. What were the tests that were done? Were they done correctly, completely? Are there any missing information that can help you select therapy, and so on? The other thing is genetics is becoming more and more important, not just for predicting risk and managing risk, but actually selecting therapy. Genetics is now being covered by insurance. When we run a genetic test at Protean, we actually run all 22,000 genes so that we can also get information about your other risk factors and so on. And it's sort of important because if you're working under insurance, insurance might only pay for one genetic test in your whole lifetime. So getting the right test is a good way to start. And so running a test that's a whole exome, that information is yours to keep for the future. And so you can keep going back to it and say, are there any new discoveries about another gene? There's a gene associated with cancer response. There's even genes associated with COVID risk, with hypertension, with other things. All of that information you have once you run the genetics. The other thing to know is that cancers can change. So after you've had a treatment, you may want to retest a cancer with a blood test to make sure that you know what you're actually treating, and if there's any treatment options that might now be available for a patient. And also, more and more clinical trials are becoming available. Some patients are scared about clinical trials, but I say, no, clinical trial is the best care you can get. You get standard therapy, you get access to an approved experimental agent that's shown to be effective in preclinical work. It gives you early access. You might get a transformational access to a therapeutic. Only 3 or 4% of patients get onto trials, whereas I think almost every patient could potentially get onto a trial that can really improve their ability for outcome and really give them access to innovative and key therapy that are coming. Second opinions are important. The field is changing quickly. Clinical trials have high value. Get your own results back so that you own it, that it's available to you so that you can share it if you need to. And it's really important that you have an advocate, because if you're not well, you need someone who's going to be on your side to guide you through that, to work with your oncologist and so on. If you're interested in working with Protean is very patient-focused. We want to be a guide and a helper. We're there to help. We've got a team there that can work with patients. Just a couple of other things there. The other tool that we use is a virtual tumor board. A virtual tumor board is an important thing where the information is loaded into this, where the clinical information is loaded for a patient. This is at your permission. It's in a HIPAA-secure environment. It can be shared with oncologists of your choice. They can come in. The oncologist can review the information. There's actually tools in here to help the oncologist look at guidelines, look at clinical trials. They can invite other experts in to discuss a case. Pathology is in here, radiology is in here. It creates a very powerful environment where doctors can collaborate with other experts of their choice, where they can organize the information. All the reports are organized here. Much, much more intuitive and powerful than the electronic medical record. I've used this with all of my patients that can work with their oncologist using a tool like this. We've taken care of patients in Australia that I've never met. There's a young person there who had an unusual tumor. We were able to sequence it, find out that he was eligible for a trial that was actually only available in France. We talked to his oncologist in Australia, reviewed everything. They said because of the evidence, they'd actually open the study in Australia, make it available to that child in Australia. So a tool like this can be extremely powerful for bringing advances to patients from around the world. So with that, I'll stop and open the floor to any questions that you might have.
So if you want to type any questions in the chat, it should be at the bottom right of your screen. We can address any questions.
Yeah, and like I said, it's a really exciting time. I have a lot of hope for the future in that using these advanced tools with immunotherapy, there's nanomedicine where we can target cancer with these nanoparticles. There's cell-mediated therapy where we can create targeted T cells. There's even oncolytic viruses that can be programmed to attack cancers and so on. So it's a really exciting time in terms of the advances in therapeutics. And actually, one of the biggest challenges are that if we're going to run clinical trials, that there often aren't enough patients. And if the patients aren't getting access to them, we really need to make the trials available so the patients understand, are these trials suitable for them? Are they eligible? The other advantage of a trial is that usually all of the costs are covered so that there isn't any cost that can be access to these therapies without any cost to insurance and so on. So trials can be extremely effective for accessing current and very high quality treatment.
Great. Thank you, Dr. Magliocco. We don't have any questions, so I just want to thank you again for joining us this evening. It's been a fascinating presentation, and we really appreciate your time.
Thank you so much for the opportunity to speak to your clients and your partners. If they have questions, please drop me an email, give me a call. If you'd like to talk about your case with me, you can absolutely arrange that as well. And really wish everyone all the very best of health. A holistic approach is the way to go. Good nutrition, good sleep. Have a very strong program for addressing your illness and your cancer. We're here to help. Keep up the great work at Karuna, and thank you for involving me with this. Thank you for inviting me.
Thank you, and thank you for coming.